concurrent with the complex forearm fracture and dislocation, which we call the Gallagher fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture of a 17-year-old gentleman, and the forearm Gallagher fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Gallagher fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Gallagher fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Gallagher fracture. So we did for minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail, and technique was minimally invasive. And whereas in this left radius, the Gallagher fracture, we did tense nailing. In this case also, the 2 millimeter tense nail is used. Usually you use a 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union. But this is the functional result. You can see that supination, pronation, and wrist movement, erection and extension all are present. And the tense nailing is provides sufficient stability for secondary union even in length critical fractures, because the narrow canal and the length should be maintained to, and DR, UJ should be reduced properly. We followed the throughout 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirms that interlocking nailing of femur and TENS aids higher union rates and excellent functional outcomes this approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did 10. So this case was published in International Journal of Orthopedic Sciences. Provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. Hence, is less invasive, resulting in smaller incision. After the study between March 2020 to March 2025, on 25 cases of the displaced fracture of the clavicle, the age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nerve. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the radiological, typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of communicated fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is the transverse and short of the fracture. So the patient lies supine with affected limb elevated and hanging outside the table, so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, there is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious, because the heart and the lungs are like vital structures, are waiting for your instruments to escape. So this is the very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb at the 2 weeks, the wound inspection and the suture removal at the 6 weeks, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally, if required, the implant was removed at the 12 weeks. The 6 month final follow-up was 20 to 50 ml in all our cases. So the post-operative observation, excellent results, 26% of patients, whereas the good results were found in 16% of cases, whereas the 4% was the figure for the fair as well as the poor results. So the complications, the nail bite count, superficial infection, and malunion each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases, the radiological as well as clinical picture. As you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was used to reduce the fracture, only the thumb and the index finger was used to reduce the fracture, and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen always. Many times we require the mini open reduction of the fracture. So this is another case we did the 15B1 fracture has been treated by titanium elastic nailing. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. 1 bump is due to secondary callus formation, and other at the anti site you can see that there is hardware progress. So this is another case of the mid-third fracture treated by titanium elastic nailing. Yet another case 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. And the indication of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS nailing is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here. ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापैटरल नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद से अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है RCT नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म के मदद से गोल करने के बाद, होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे, और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल, और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है। अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को, उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सी आर्म को एडजस्ट किया जाता है कि वो गोल दिखे, और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सी आर्म को एडजस्ट किया गया है, और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है, और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the femur or other leg. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blunt dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intramedullary canal so that it can enter in selected abject entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view, this is the lateral view, this is the epi view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the epi view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3, at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a healing process and netting process, the